question now. What is white spot lesions? White spot lesions are usually white opacities or chalky white appearance on the surface of the tooth, which might occur due to poor oral hygiene, plaque, bacteria, and acid accumulation on teeth. Article by Francesco et al. In the year 2008, he defined white spot lesion as a first sign of a carious lesion that can be detected with naked eyes. White spot lesions are usually seen on the surface of the tooth and also around the brackets, especially in the gingival margin. These white spot lesions are crescent in shape, and this appears after 1 month of orthodontic bonding. Article by Colgate et al. In the year 1982 in American Journal of Orthodontics, he reported that 50% of patients with white spot lesion at least on single tooth after removing the bonded appliances. Now we will see what might be the cause for white spot lesion. Firstly, it might be due to dental fluorosis. This occurs due to high fluoride content when adult tooth is developing. It might also occur due to congenital hypomineralization of the teeth. This occurs due to infection in infants. And also it might be cause for white spot lesion might be also due to molar incisor hypomineralization. This occurs due to abnormal development of enamel during maturation stage. And we also see white spot lesion due to decalcification of enamel due to fixed appliances. This might be due to improper oral hygiene maintenance, due to increased plaque. If oral prophylaxis fail, what you need to do is you need to keep an equilibrium. If equilibrium tips and scales go down, you see more of demineralization than remineralization. And demineralization is brought about various bad effects such as the dietary habits, which results in producing acid on the surface of the tooth, which results in chalky white appearance. It is important to recognize early and act quickly. Whereas remineralization is brought about by various products and factors such as calcium, fluoride, and silica present in the saliva, and also by various products by using the toothpaste, high content of fluoride toothpaste, mouthwashes, and dentifriers. Many studies have shown that up to 96% of orthodontic patients can develop white spot lesions, but maxillary lateral incisors was the highest incidence of white spot lesion, followed by canine, premolar, and central incisor. This is a classification given by Banks and Richmond for enamel decalcification index. Level 0, there is no calcification. Level scores tell you that there is no decalcification on the enamel surface. Level 1 indicates that there is less than 50% of decalcification on the tooth surface, and level 2 indicates that there is more than 50% of decalcification on the tooth surface, and level 3 you can see here there is decalcification resulting in cavity cracking of the surface. My aim of my research work was to compare the regression of white spot lesion treated with 3 commercially available material. One is the GC tooth mousse, Colgate phosphor mouthwash, and shine. Objective of my research work was to measure and compare the degree of regression of white spot lesion during orthodontic treatment achieved by using 3 commercially available materials. My research work was an in vivo study carried out in our department, and the study protocol was reviewed and approved by the Institutional Ethical Committee. Patients undergoing orthodontic treatment using fixed appliances in the postgraduate orthodontic clinic were included in the study. Inclusion criteria were patient age between 12 and 25 years, with fair oral hygiene, with satisfactory general health, with modified Golic index score of 2, which indicates visible white spot lesion, at least 6 months of orthodontic treatment remaining, with maxillary and mandibular anterior teeth bonded with fixed orthodontic appliances. My exclusion criteria were patient with enamel hypoplasia that results with very thin or absence of enamel, amelogenesis imperfecta, where this is the congenital defects of enamel formation during maturation stage, and fluorosis is increased level of fluoride content during the adult tooth is developing. Active periodontal diseases, where you see the inflammation of the gingiva due to increased level of plaque, and active dental caries were excluded in my study. So my randomized clinical study, my research study was done by single blinded randomized prospective clinical trial comprising 80 patients categorized into 4 groups, 1 control group and 3 experimental group using block randomization. A single blinded is where the examiner, where the researcher will be knowing what intervention he is giving to the participant till the trial is over. And randomized prospective clinical trial is one in which the subject of a population are allotted into 2 groups. One is the control group and other is the experimental group to receive and not to receive experimental preventive therapeutical interventions. And we have distributed the subject using block randomization, where we have distributed equal numbers in each groups. Here control group is group A and experimental group is group B, C and D. Group A is a control group in which we have used Colgate strong toothpaste. Group B is experimental group, which we have used GC tooth mousse, phosphor mouthwash and Shinem. Subjects were instructed to use the designated identifiers, mouthwash and photographs were taken at baseline, 3rd month and 6 months, and white spot lesion were reassessed in the maxillomandibular anterior teeth. Results of my study showed that all the 3 groups had an improvement in white spot lesion, but group B had shown a greater difference in mean value of decalcification index scores. Now we'll see the remineralization of the teeth, how the remineralization of the teeth is brought about. And this can be brought about by various resolution procedures and products such as increased fluoride concentration, calcium phosphopeptide amorphous calcium phosphate, calcium sodium phosphosilicate class, microabrasion and composite restoration as an aggressive technique. Now decreased white spot lesion is brought about by 2 mechanisms, that is remineralization by calcium phosphate and fluoride, which is present in the saliva, and removal of the dissolved enamel surface, exposing the underlying enamel crystals which are tightly packed and thus reflects light properly. Fluoride acts as a remineralizing agent by depositing fluoroapatite in a place of dissolved hydroxyapatite. High fluoride concentration results in remineralization of white spot lesion via hypermineralization, which gives unsliced tooth appearance. And this unsliced tooth appearance is because of surface remineralization, which inhibits the ion into the subsurface of the lesion and thereby affecting the light touching the tooth surface. And we have used calcium phosphopeptide amorphous calcium phosphate as a remineralizing agent in my research work, and this carries, and the marketed name is GC tooth mousse, and this carries a high amount of calcium and phosphate ions to enamel and assists in remineralization with more aesthetically pleasing results. This acts by binding the tooth surface along with a plaque coating it. This results in maintenance of high concentration of calcium and phosphate, which in turn stabilizes the amorphous calcium phosphate, which both of which play an important role in remineralizations. Next, remineralization which we used in our study is calcium phosphate, calcium sodium phosphosilicate glasses, and this is marketed for dentine sensitivity and also showed interest as a remineralizing agent, and this is believed to contain high amount of calcium and phosphate on the enamel surface. And next remineralizing agent which we have used in our study is novamin, and this is composed of inorganic calcium phosphate minerals and silica. The method of action is that it releases sodium ions when it interacts with the oral fluid, and there will be an increase in pH, which in turn releases the calcium and phosphate to form a layer of calcium phosphate. This layer crystallizes to form hydroxycarbonate layer, which fills into the whites of enamel crystals. This is the previous classification given by Garlick and co-workers, and this calcification index was measured on the anterior teeth using modified Garlick index. 0 scores indicate absence of white spot lesions. One indicates visible white spot lesion without any surface interruption. Score 2 indicates visible white spot lesion with a roughened surface that does not require a restoration, which we have included in our study. The score 2 we have taken in our research work to analyze the white spot lesion, and score 3 is visible white spot lesion with surface interruption, and score 4 is cavitation. A statistical analysis were done by using SPSS version 23, and normality assumption was tested using Sapir-Whorf test, ANOVA, and post hoc Tukey test were done for intra-group and inter-group comparison respectively. The results of ANOVA at baseline showed statistically insignificance as p value is more than 0.05, and statistically significant difference were seen at the 3rd month and 6 months as p value was less than 0.05. Post hoc Tukey test showed a statistically significant difference between Colgate strong toothpaste and GC tooth mousse at baseline, and also between Colgate strong toothpaste and GC tooth mousse and China at 6 months, while the rest of the comparisons were insignificant as shown in the table 2. The results of our studies are in concurrence with previous studies. The study done by W.S.L reported that high concentration of fluoride varnish reverse white spot lesion at 3rd and 6 months following devarnishing. Study done by Beeson et al. Over a period of 6 weeks showed using a fluoride-aided chewing sticks have shown a greater remineralizing effects on white spot lesion. And combination of GC tooth mousse with 0.5% sodium mouthwash and fluoridated dentifrices demonstrated a significant improvement in white spot lesion. Study conducted by Anderson et al. Using GC tooth mousse in the initial period of orthodontic treatment has a greater remineralizing effects of white spot lesions. This was a randomized controlled trial done by Robertson et al. However, there are studies in contrast to our results which have reported an insignificant change in the size of white spot lesion over time in groups using the fluoride delivery system. Behrens et al. Concluded that the use of GC tooth mousse with fluoride paste supplementary to oral hygiene over a period of 4 months had no clinical advantages. A study done by Brochner et al. For a period of 1 month and 60 adolescent patients were selected which were given daily application of GC tooth mousse or standard fluoridated toothpaste to treat white spot lesions. The results were then analyzed by laser fluorescence and visual scoring from the digital photographs. The results showed 26 to 58% reduction in the mean area of the lesion, but no significant difference were found between GC tooth mousse and the control group. The results of my research work showed that GC tooth mousse was superior in its ability to remineralize white spot lesion. The multifactorial anti-kerogenic mechanism for GC tooth mousse has a threefold mode of action. Remineralization of enamel is brought by preserving the supersaturated state of enamel minerals, calcium and phosphate in plaque, which slow down the initiation of biofilm and suppresses the bacterial adherence to the tooth surface, which in turn reduces the pH in the oral environment by acting as a buffering agent. I would like to conclude my research work by suggesting all the 3 commercially available products, GC tooth mousse, Colgate phosphor mouthwash and Chyanum showed regression in white spot lesion over a period of 6 months. But GC tooth mousse proved to be most effective mean of treating white spot lesion over the regimen. Thank you one and all for patient hearing. Any questions?
Okay, thank you very much for your presentation. And I will try to continue with Farah again. Hopefully this time we will be able to hear Farah. Farah, are you here with us? Yeah, can you hear me?
Can I stop sharing the screen?
This time, yes. Okay, perfect. Dr. Bali, thank you very much for your presentation. Now I need to...
I'm doing that.
Thank you very much.
Thank you so much.